So we all know in the elbow, as the most of the structures are superficial, that is within 4 centimeter. So the probe we are going to use in whole of the elbow are the linear probes, not the curvilinear probes. So the linear anti-transducers we commonly use for the elbow joint and usually in a frequency range of 5 to 17 megahertz. Today we will be using a 20 megahertz probe. So depending on the depth, you can choose your frequency. Now coming to the indications in which condition we are going to go for the ultrasound of the elbow joint. First of all, any injury, pain, trauma, swelling. We may suspect that there might be a tendon rupture or a ligament rupture. We can check with the ultrasound. Then we can check for the dislocation and fracture. But remember, for the bony pathologies, obviously the X-ray is a better choice. Then there are certain conditions which are overuse syndromes, like as I told, the lateral or medial epicondylitis. Today we'll be describing a lot on the lateral epicondylitis. Then there may be encephalopathy of the triceps. There may be chronic disorder, chronic injury to the olecranon bursa and giving to the olecranon bursitis. If there are such swelling and pain inflammation, we can go for that. It is usually associated with the inflammatory disorders like rheumatoid arthritis and other inflammatory disorders. There may be associated bursitis, there may be intra-articular diffusion, there may be the entrapment neuropathies. Now, in this area, the most common entrapment neuropathy, what we encountered is the entrapment neuropathy of the radial nerve. So, we have to check for the radial nerve, especially to detect the neuropathy. There are some specific areas where the entrapment is more common, and if there is entrapment, there is dilatation, and there is just before the compression, there is dilatation. By looking at it, we can diagnose whether there is the entrapment neuropathy present or not, and it can be treated with the hydrodissection at that area. The cubital tunnel part is already discussed yesterday, so we will not be uh, repeating. The other thing, that is the radial tunnel syndrome that I am always discussing. It's an entrapment neuropathy, so we will be discussing that part today. Now, flow of the USG examination for the elbow. Usually, when you are examining with the ultrasound, always look for the physical appearance and the clinical findings of the patient. Okay, first take the history, examine the patient, select the area to be scanned, whether you have to go for the anterior, medial, lateral or posterior, which area you want to do. You just select that area and scan in a methodical way. Now, what are the common things we can scan for the lateral elbow? The common extensor tendon. As we told that this tendinopathy is quite common. We have to look for it if there is a lateral elbow pain. We have to check for the radial collateral ligament complex, which includes the radial collateral ligament and lateral ulnar collateral ligament as well. Then we have to check for the dynamic scanning for the common extensor tendon. Then we have to check for the joints as well, like radiocapitular joint, which lies the lateral side of the, and we have to do the stress test at that joint as well. In the posterior elbow, there are triceps. So we can have to look for the triceps either encephalopathy, or we can look for the partial or complete tear of the triceps muscle. Then we have to evaluate for the posterior elbow joint, especially the olecranon fossa. If there is effusion, there might be fluid. Then we have to check for the loose body. And in the posterior medial part, we have to check for the ulnar nerve as well. And ulnar nerve compression is one of the most common entrapment neuropathies in the elbow. Coming to the elbow anatomy, I think previously also discussed, so I'm not going into detail. It's a complex structure on three bones. It is the humerus and the two bones below, that is the olecranon and the radius. Not olecranon, ulna, but tip is the olecranon. The other side it's the radius. They are forming this joint. Now, on the movement, there are two elevations. One is known as the capitulum and one is known as the trochlea. So with the trochlea, ulnar usually attaches, and with the capitulum, the radial head attaches. So they move over these structures to make the gliding smooth. Now, in terms of range of motion, the elbow can move at a range of the flexion extension of around 150 degree. It can move in the pronation around 75 degree and supination around 85 degree. An optimal position is 90 degree flexion in mid-prone position and mid-supination, or you can say mid-prone. So in this area, in most of the elbow examinations are commonly done. Now there are ligaments that we'll be discussing that actually makes the elbow and pulls it in a strong way so that ligaments remain taut during the movement, so that the joint can move in a coordinated and smooth manner. Now, this is what I was telling just now. So, this is the lower part of the humerus. So, there are some elevations and depressions. There is one circular elevation at the lateral side that we will be discussing, we will be seeing today. It is the capitulum, and which joins with the head of the radius. So this is one joint, that is the radiocapitular joint, and another is ulnotrochlear joint. So we have two fossas just above it. One is the radial fossa, which accommodates the margin of the radial head, and there is coronoid fossa, which accommodates this coronoid process. So over that, the elbow glides smoothly in and out. So in this side, we have the radiocapitular joint, and if there is inflammation, that can cause pain. Similarly, in the posterior side, we have the tip of the olecranon, which actually goes inside this olecranon fossa. So it helps in the movement, and in this movement, the stability is maintained by this hook-like structure of the olecranon. And we have to check for these fossas because in the tip of this olecranon, the structure attaches is nicer, and it is slightly towards the distal to the tip end, and this helps in proper flexion, extension of the joint. Now, there are ligaments. One most important is the ulnar and the radial collateral ligaments. In fact, in the lateral side, we have three ligaments. One is the radial collateral ligament, one slightly posterior to it, that is the ulnar, lateral ulnar collateral ligament. Below, we have the annular ligament of the radius. So these three structures strengthens it from this side, and just below these ligaments, there is the capsule of the joint. Now, time to the lateral elbow proper. It looks like this in the mid-bone position and in the 90-degree flexion. So we have the tuberous, we have the neck, and we have the head. So with this capitulum, the head attaches, and there is the radial notch, and tip of the olecranon is here. Now coming to the ligament part. In the ligament part, as I told, there are two important ligaments here. One is the radial collateral ligament, one is the lateral ulnar collateral ligament. The lateral ulnar collateral ligament extends from the lateral epicondyle to the ulna, and some part also blends with the annular ligament. Annular ligament rounds around the head and neck of the radius, and it attaches the radius with the ulna, and with that the radial collateral ligament attaches, so it forms this lateral elbow ligament complex. And understanding this lateral elbow ligament complex is very, very essential. Especially you have to remember about this lateral ulnar collateral ligament, because it's the ligament that remains taut throughout the range of motion in flexion and extension, giving the elbow joint the stability that is required by the joint. Now, let's see one by one. So lateral elbow ligaments, as I told, there is one side, it is the radial collateral ligament, one is the lateral ulnar collateral ligament, and it attaches with the lateral epicondyle and inserts into the radial notch of the ulna. So this is the posterior part, this is the anterior part, and the main function is to stabilize the ulnohumeral joint. Now, lateral ligament of the elbow, among which there is another ligament, annular ligament I have told about this joint. In this joint, as told, it encircles the radial head, attaches with the radial notch of the ulna, and it makes the synovial surface smooth, and it actually attaches the radial head with the ulna. I'm just repeating the same thing, so I'm just moving forward. Here also, it is showing the lateral ulnar collateral ligament joining. Now, it is important to understand muscles, because here a number of muscles are getting attached at the lateral epicondyle. Similar to medial epicondyle, lateral epicondyle is very rich in the muscle attachment. So this area, it joins as a common extensor tendon, and this area is very prone to tendinitis, and this condition is known as the lateral epicondylitis. It is very common in case of players like tennis players, cricket players. So the disease which is called is the tennis elbow, but it is not that, as it is named after some sport. It is always associated with the sport. A lot of the normal people, including the housewives, they can develop this condition due to chronic injury of this chronic overuse syndrome at that area. So let us go and let us check the muscles. What are the muscles we are having? Now remember, if this is the joint where all the extensor muscles they are attaching, two muscles are exception. One is the brachioradialis and another is the extensor carpi radialis longus. Because they do not take origin from this lateral common extensor tendon origin. Rather, they takes origin from the lateral supracondylar ridge. First takes the brachioradialis. I am sure in yesterday's class or the last week's class, I have already seen the brachioradialis in a very good way. And just lateral to the brachioradialis lies the extensor carpi radialis longus. Then we have the extensor carpi radialis brevis. Then we have the extensor digitorum, then digiti minimi. Then we have the extensor carpi ulnaris. Then we have another small muscle that is known as the anconeus, actually extends from the olecranon tip to this area. So we can see these are the muscles which lies in the lateral side of the elbow. Now coming to the brachioradialis and extensor carpi radialis longus, both the muscles taking origin from the supracondylar ridge from over. One is above, that is the brachioradialis, one is below, that is the extensor carpi radialis longus, and they are independent from the common extensor tendon. Now, in the common extensor tendon, we have five muscles, like they are the extensor carpi radialis brevis. Okay, then extensor carpi radialis longus is not a part, I have already told. Extensor carpi radialis brevis one. Then we have the extensor digitorum, then we have the extensor digiti minimi and extensor carpi ulnaris. And just below these muscles, just deep to these muscles, we have another muscle which is very, very important in our lateral elbow, that is the supinator. Okay, it has two heads of origin. One is known as the superficial head and the other is known as the deep head. The superficial head arises from the lateral epicondyle and along with the annular ligament. The ligament is over this, so the superficial head taking origin from it. And the deep head arises from posterior fossa supine, this supinator fossa of the ulna. And there are this inserts into the proximal aspect of the radial shaft. And the superior part of it is known as the arcade of Froche. And this is very important because it is a common area of entrapment for the radial nerve at this area. And these are the three nerves which lies around the elbow. So the radial nerve which coming out from the radial groove, and here it lies in between the extensor carpi radialis longus brachioradialis, and then it moves just over the supinator. Just above the supinator, it divides into two. One is the deep muscle, which becomes the posterior interosseous nerve, and other becomes superficial, which remains superficial. And this deep branch of the radial nerve, which is the posterior interosseous nerve, they travels between the two layers of the supinator and two heads of the supinator, and they continues below as the posterior interosseous nerve, and the entrapment here causes the radial tunnel syndrome, also known as the supinator syndrome. The median nerve and the radial nerve I have already discussed. I am not discussing, okay? Because previously we have already discussed these two things. Now coming to the hand positioning for the lateral elbow. Now lateral elbow can be examined, I have already told, in supine as well as the sitting position. If you are examining in the sitting position, usually hand is 90-degree flexed and in the mid prone position, and we have to start the elbow ultrasound. Right? What are the structures we need to examine? First of all, it's the common extensor tendon, then radial collateral ligament complex, then dynamic scanning of the stretching of the CT, and radiocapitular joint with the dynamic scanning. Before going to the scanning, I'm just stopping and I'm just showing the things in the anatomy map so that the concept is very clear to you. So here, as I told, we have two ligaments here, 1 and 2. This is the radial collateral ligament. This is the posterior part of the collateral ligament, or you can call it lateral ulnar collateral ligament as well. This is the annular ligament, and below we have the capsule of this joint. So this becomes the tendinous capsular part of it. Now coming to the muscular part. In the muscular part, as we all know, this is the big muscle, that is the biceps, but at the elbow, this muscle is not big. It becomes a small tendinous junction that you have already seen. I'm hiding this. Now, below the biceps, we have the brachialis that we already know from our previous class. So, this bulk is above at the arm level, it is very small, but as we come down, this becomes the largest muscle and in front of the elbow, which having the starry sky appearance on looking under ultrasound. Now, we are removing that also. Now we are having this muscle, this is the brachioradialis. And you have to look closely between this brachialis and the brachioradialis. So in between this muscle, there is a fascia. And within that fascia, what moves is the radial nerve. But on coming from posterior, so it comes from the radial groove and comes like this. And in the posterior side, just behind the brachioradialis, there is another muscle that is the supinator. It becomes two branches and one branch remains superficial that will be again found here close to the anatomical snap box to continue as a perfectly sensory nerve, and other branch that goes inside this muscle is the supinator and at the two heads of the supinator and to become the posterior interosseous nerve that is the main motor supply of the extensors, the forearm. Now, here we have the extensor carpi radialis longus. Let me hide it. Then we can see the two heads of the supinator. And below we have the extensor carpi radialis brevis. Usually at this point they are remains very together. And then we have the extensor digitorum. Then we have the extensor digiti minimi. And then we have the extensor carpi ulnaris. And here the muscle is the anconia. So that is how the lateral part of the elbow is. If you come at the posterior part, so below I have told only the muscular part, bulky part here mixed by the anconeus muscle, which is a small triangular muscle, but at the tip of the olecranon, slightly distal to it, attaches the triceps muscle. Our triceps has three heads. One head I have already shown during the shoulder, that is the long head that starts from the infraglenoid tubercle. Then we have two more heads of the triceps and the radial grooves divides it into two sections. So if we just see these are the, let me hide the deltoid as well. Okay, so you will be able to see all three heads together. So in between two, you can see the medial head of the triceps. So this is the long head of the triceps. I'm not pointing because both are pointed together. This is the long head of the triceps. So when if you are hiding the other muscles, we can see it goes into the infraglenoid tubercle. And in the supraglenoid tubercle, which muscle that attaches? It's a question to you because we have already covered the shoulder.
Biceps.
So always try to relate. Please, in the
Long,
supraglenoid tubercle, which muscle is getting attached?
long head of biceps, sir.
Perfect. This is the long head of biceps. Okay. And in the infraglenoid tubercle, it is the long head of the triceps. Okay. Now, this from the shaft of the humerus, especially from the posterior side, in between two heads, there is radial groove through which the radial nerve passes. And in between two heads goes the radial nerve. So we have all three heads of this triceps here. But these three heads join together to form the single triceps suri and single tendon and they attaches to the olecranon. Now what are the problems might happen here? First of all, there might be enthesopathy, there might be bursitis at the tip of the olecranon causing the olecranon bursitis, which is also known as another elbow name. What is the name of the olecranon bursitis? Can anyone tell? It is a student's elbow. So there are a lot of elbows. One is the golfer's elbow, that is the medial epicondylitis. One is the uh, tennis elbow, that's the lateral epicondylitis. Then we have the olecranon bursitis, that is the student's elbow. And there is another elbow as well. It is the climber's elbow. It is the inflammation of the brachialis. So here it is the triceps that attaches. So what other common pathologies which might affect? Number one, here there might be partial or complete tear of the triceps tendon. There might be inflammation of the triceps. And if we just hide the triceps, there is one depression that is known as the olecranon fossa, and through which the tip of olecranon goes in. And here also it might suffer from inflammation, okay, because of the synovitis, there might be inflammation at this area, there might be fluid accumulation here because of the infection it might happen. So these are the pathologies which commonly affect this area. But there is another pathology related to the triceps. It is known as the snapping triceps syndrome. I'm just discussing one by one. I will show the related pictures as well. So in snapping triceps, what happens? This medial portion, medial head of the triceps glides over the epicondyles, and this medial epicondyle, and this is known as snapping triceps syndrome, but it is not a very common disorder, so you will not going to discuss it much. But you should know there is something called like the snapping hip. There is also snapping triceps syndrome. Now coming to the nerve. So let me show you the nerve. So here, just if we remove the superficial nerves, in the lateral part, I have already told that the main nerve here is the radial nerve. So let us hide the brachialis. So we can get this nerve here at this point, radial nerve. Now, as I told, just above this supinator muscle, it divides into two. Deep goes inside the supinator between two heads and the superficial continues. Okay? And deep becomes the posterior interosseous nerve, which supplies almost all extensors of this hand. Okay, forearm. So let's move and let's back to the presentation. So let us see how they looks on the ultrasound. So if we look at the lateral portion of the head, we'll be able to see two structures. One ligament just rounding around this. This is the head of the radius, and just around it we'll be able to see the annular ligament, and there is a cartilage over the radial head. That's why just above the radial head it looks a little hypoechoic. Slightly superficial to it, we'll be getting the common extensor tendon. Okay, and these are the two structures that is very important to look at this point. Now, to examine the radiocapitular joint, you have to go either from the lateral or from the anterolateral to find out the radial head, where you can see the annular ligament in a cross-sectional view or a short axis view, and you can get the humeral capitulum, and both of them is having the hypoechoic cartilage over it. And this area is very important because if there is inflammation at this area, there might be fluid accumulation here at this point. So you have to evaluate this area for the effusion. Now coming to the annular ligament that I have already shown. So it is on a much different view, slightly go below, and we will be able to see the annular ligament in the cross-sectional view and in the longitudinal view. So here we can see the annular ligament in a longitudinal view or long axis view. Then we can see annular ligament in a cross-sectional view. Now coming to the common extensor tendon. So to find out the common extensor tendon, the simple way is to palpate the lateral epicondyle. First palpate the lateral epicondyle, put the probe along the direction of the extensor tendons, and then you will be able to see this down sloping area. So above 50% of this down sloping area is the attachment of the common extensor tendon, and the below 50% is the attachment of the radial collateral ligament. They both goes together. The ligament part attaches around the radial head near close to the annular ligament, whereas the muscular part, if you follow, they will become muscular and will continue as the extensor muscles of the. Now we have to check the lateral collateral ligament in both short and long axis. And what for you have to check? You have to check for continuity of the fibers, whether there is any hypoechoic spots or not, whether there is large hypoechoic areas or not, whether there are any calcifications or not. So if there are small hypoechoic areas, that could be the sign of the epicondylitis, and in case of calcification, it might look like calcified area. So this is how it looks in a picture. So it's a larger picture to show you this down sloping area. So it's important to note the margin of the bone. It should be from the lateral epicondyle, it should be sloping down towards the capitulum, and here it is the radial head, and just above you can see these is the origin of the common extensor tendon. These tendons are becoming muscles from this area. And remember, in previous days when you used to give steroid for the lateral epicondylitis, we usually prefer an area which is slightly heavy, means you are at the muscular area. not over the tendon, because that time we are not sure that whether we can inside the tendon or we are superficial to the tendon, because at this area all the structures are very superficial to the skin and don't give steroid very close to the skin because there will be skin sloughing. So in that way, what you used to do, you used to inject more over at the muscular part rather than the tendinous part. But nowadays with the ultrasound, if you can give PRP, then you can give PRP inside and around the tendon as well. So this is how, it's my drawing, so it is not good. You can check the structures in a linear and easy way. Okay. Now coming to the causes for the lateral elbow pain. So what might cause lateral elbow pain? First of all, I have told you, lateral epicondylitis is the most common, and it is common in players, it is common in housewives, it is common in persons who carry weights. Okay, so that is the lateral epicondylitis. Then there might be lateral ulnar collateral ligament rupture, inflammation, or injury. In both of the cases, there will be the inflammation and pain at this area. And if the lateral ulnar collateral ligament is involved, pain will be there in flexion and extension as well. Then we have the posterior interosseous nerve entrapment, and there are a lot of areas where it can get entrapped, but the most common is the ligament of Froschet, as I have told. Okay. Then we have the radial nerve that could be a source of the pain, and we have the radiocapitular joint, where inflammation at the radiocapitular joint might cause the pain at this area as well. So, what are the changes what we might expect in the lateral epicondylitis? First of all, in early cases, there might be nothing. That means it is not that every time you are finding a lateral epicondyle pain and you are seeing it under ultrasound and you will get a significant abnormality. So keep in mind, this is usually what happens after the class. If one of these I am expecting, all the lateral elbow pains, the time to expect it. But remember, in early cases of the lateral epicondylitis, everything might be absent. So, what is the earliest sign on the ultrasound? It is the earliest hypoechogenicity, which is basically because of the collagen degeneration and the fibroblast proliferation. So, that is the hypoechogenicity, and this is not continuous. This is only in small areas of the hypoechogenicity. That is the sign for the earliest sign for the lateral epicondylitis. Other changes, calcification, color signal changes, especially if it is the acute and inflamed, that is hyperemia, then the color signal changes might be possible. But again, it is not possible in present in all the cases. So, what are the common things? It is the hypoechogenicity and sometimes the thinness and change in diameter of the lateral epicondyle. This common extensor tendon, that could be a possible. There is one studies are going on mainly on the stonoelastography, which is showing some significant changes in the lateral epicondylitis. Now, this is the featured in the lateral epicondylitis in the short and long axis. You can see these hypoechoic areas within this muscle. So, these are signs of the inflammation. So, this is in the long axis and this is in the short axis. In the asterisk part, you can see these are the areas which look hypoechoic, and this could be a possible cause of the elbow pain here. And it is in a comparatively early stage. Now, if the patient is in advanced stage, then you can get a large area of hypoechogenicity and lot of pain, inflammation at this area. So, this is possible in the advanced case of the disease. Okay. So same way, we are seeing the lateral epicondyle and you see the classic appearance, what was there in previous images is not there. The classic fibers. In the normal, you see these fibers, they are moving. These are absent. See, these are the normal fibers moving. These are absent on these areas, and you can see these are some large hypoechoic areas. And in case of injury or acute condition, along with this hypoechoic area, if you put on the color Doppler, you can see the color signals, which is a sign of hyperemia at this area. Now, in case of calcification, in X-ray, you might see a calcified image, and in ultrasound, you can see the acoustic shadowing, and this is the sign of the calcification of the lateral epicondylitis. It is mainly because of the common extensor tendon, and there is calcification inside. Now, what are the other possible diagnoses which might be mistaken as the lateral epicondylitis? As I told, one is the radiocapitular arthritis. You have to check for that as well. Then posterior radial tunnel syndrome or the posterior interosseous nerve compression. That could be one possible thing. Then there might be cervical radiculopathy. Do not forget this diagnosis because this is sometimes missed. Everything you are looking normal, everything you are taking is normal, but the patient is complaining of pain when the pain hand is mostly in the down on the normal position. The pain reduces while taking the hand at the back. You should always check for the cervical radiculopathy. But remember, shoulder abduction test is not always positive in cervical radiculopathy. So if you are suspecting a C5 radiculopathy or C6 radiculopathy, you should examine with an MRI. So that is also an important differential diagnosis. Then inflammatory arthritis like rheumatoid arthritis, spondyloarthropathy, they can also cause the tendinitis and inflammation at these areas, and the myofascial pain of the adjacent muscles. That could be another differential diagnosis for this count. Now coming to the partial and the full thickness tears. So here you can see this partial thickness tear in the lateral epicondyle. So this is also possible, and you have to look for the partial or full thickness tear. Here you can see it is a full thickness tear, but you can see the whole area is hypoechoic, and this is the retracted area what you can see in this star-shaped manner. Now, you have to check for the radial collateral ligament. Here are the fibers of the radial collateral ligament. Look below, and these fibers are should be similar. That means their normal fibrillar appearance should be there. And sometimes, if you say that it's possible to differentiate between the upper fibers and lower fibers, it is not. But remember, the lower fibers are usually from the radial collateral ligament, and they usually ends here, whereas the upper fibers they usually continue at the common extensor tendon. Now, to see the lateral collateral ligament, we have to actually take the probe slightly towards the posterior side, and that is to be evaluated because this is also very much prone to the injury. This is the lateral ulnar collateral ligament, and lateral ulnar collateral ligament tear may be a cause of the posterior lateral elbow pain as well. Okay, so here we can see it is between the humerus and eye. So this is the ligament between the, this is the lateral ulnar collateral ligament. Annular ligament, I have told you guys, so I am not repeating it anymore. The annular ligament. Now we have to find out the radial nerve. So to find the radial nerve, as I told, we have to go in between two muscles. One is the brachialis and other is the brachioidealis. And there is a fascial plane in between. Sometimes the brachialis tendon is here. That sometimes look like a fascial plane. Don't mistake it as a fascial plane. Rather, try to find out the brachioidealis and brachialis margin, and in between we'll be able to see nerves, and these nerves sometimes stay at the above level. If you go proximally, there it is 1, and if you come down, they becomes hypoechoic and they becomes 2, and one part usually remains superficial to the supinator, other part goes inside the supinator to reach the forearm as the posterior interosseous nerve. So here you can see the radial nerve in the supinator. Okay, this is one branch, this is one branch. So once already the deep branch has gone inside the supinator. So here also what you can see close to the fascia, the hypoechoic structure within the muscle, it will be hyperechoic. I have already told. The nerves always you will be see in which background you are seeing. If it is a muscular background, it look hyperechoic. Now coming to the supinator syndrome. So it's a rare compression neuropathy affecting the posterior interosseous nerve in the upper limb, which is also known as the PIN syndrome, posterior interosseous nerve syndrome, or the radial tunnel syndrome. It might be compressed by the fibrous band, recurrent radial vessels, tightness within the suprasupinator layers, and the soft tissue muscles. I will discuss in detail in which areas it can get compressed, and also it can be compressed by the fracture of the radial head, and sometimes there is callus formation over the radial head after the fracture, and this callus can also compress the nerve. So this is the radial nerve compression, and here the pain will be at this area. Okay, so it is very important to differentiate these two diagnoses. One is the ulnar this lateral epicondylitis and the radial tunnel syndrome. Remember, And this lateral epicondylitis, the nature is more of an inflammatory pain. Inflammatory pain is mainly a nociceptive pain unless it is chronic. Whereas the radial tunnel syndrome pain is more of a primary neuropathic pain than an inflammatory pain. So the nature character, if you see in the Finnegan's pain detect tool, you might find a higher score in case of radial tunnel syndrome. There might be numbness, there might be tingling, and the signs of the neuropathic pain will be there. Whereas here it is mostly at the elbow joint. Now the test, let me show you the test. So basically for the lateral epicondylitis, what we do is known as Cosen's test. Look at my arm. So what is done in the Cosen's test? Let me take a little bit broad view. Video settings. So in the Cosen's test, the examiner asks the patient to put the arm like this. Now the patient tries to pull the arm. There I tries to extend the arm, and the examiner resists the arm through the hand. So it will be like this. But see, this hand is for the examiner's hand and the doctor's hand. So he is trying to pull it like this, and the patient is trying to put it like this. So this maneuver actually increases because of the extension. The patient have to do an extension. For that, there is pressure over this lateral epicondylis because all these muscles are attached here. So if the patient is having lateral epicondylitis, then this pain might be increased. Now, in case of radial tunnel syndrome, if ask the patient to hold flex at 90 degree and ask the patient to keep the arm in the neutral position. Now, the examiner or the doctor keeps the hand like this and asks the patient to supinate against the resistance. So when the patient is supinating against the resistance, the pain in the radial tunnel syndrome increases. So these are two very basic physical tests by which you can try to differentiate these two conditions. But remember, sometimes it is a little bit difficult, but these are the easy way by which we can try to differentiate these two conditions. Now, supinatus syndrome, which is characterized by the finger drop instead of a typical wrist drop, and which is in the radial neuropathy. That is the weakness of the extensor carpi radialis leading to the impaired finger extension and the thumb movement. And there is burning pain and tenderness over the lateral elbow, which may be present. And if you look at this nerve, usually just before the stenosis, there will be dilatation. So this feature of the nerve might be possible. And in cross section, we'll be able to see the nerve like this. Okay, so the compressed nerve will appear swollen. See here how swollen it is, and proximal inside the supinator muscle. And post-traumatic scenarios reveal a nerve entrapment slightly distally close to the radial head. And you might able to see the hypoechoic star tissue. This is the list of areas where the radial nerve can get compressed. First of all, it is just anterior to the radiocapitellar joint. There are fibrous bands which can actually block this nerve, and there is an area of compression and lash of Henry, which is the radial recurrent artery anastomosis that can actually block here. Then it can be blocked in the medial side of the external carpi radialis brevis origin. Then, as I told, at the entry of the supinator, it can be obstructed, or it can be compressed by the arcade of Froche. Then in the distal edge of the supinator, the distal edge of the supinator itself can compress it. Then there are radial recurrent vessels which can also compress. Then tendinous origin of the extensor carpi radialis brevis, that can also compress, and the fascial bands within the forearm, that can also compress. So these are the areas at the wrist where this radial nerve might get compressed. So you have to check it both in the cross-sectional view and the longitudinal view. So if you observe them carefully, you will be able to differentiate at which area it is compressed, and according to, you might go for hydrodilation or a surgical decompression. So ulnar nerve entrapment is already covered. I'm not going into detail of this dynamic testing of the ulnar nerves. And let's directly land to the posterior elbow. And in the posterior elbow, as I told, we have to check for the triceps, we have to check for the posterior elbow joint, we have to check for the loose body, we have to check for the ulnar nerve and the olecranon bursitis. Triceps muscle, I have already described the triceps muscle. and its insertion at the olecranon. And here we have to check for this area, and we have to check this muscle dynamically while moving the arm as well. Okay, and Anconius muscle is a small muscle. You remember how you have looked for the ulnar nerve? Instead of going towards the medial epicondyle, if you put the probe in the same way towards the lateral epicondyle, you will be able to see a small, here not the muscle doesn't look small, it looks large. The muscle length is small, but this area, it is the bulk of this muscular bulk is formed by this anconius only. So instead of bridging the medial epicondyle and the olecranon, just bridge the lateral epicondyle and olecranon, you will be able to see the anconius muscle. Okay, and it is assists the triceps for the elbow extension, and it stabilizes the lateral ulnar collateral ligament, preventing the outward elbow movement. That is the importance of it. Now checking for the olecranon fossa. So as I told, tip of the olecranon process joins at the olecranon fossa, and there is the joint width. And the roof is formed by the triceps, and above you are the humerus. So this is a area where there might be accumulation of fluid. So we have to check for this area, not only for this, but also for the continuity at the triceps tendons. So here you can see the triceps. Here we can see the olecranon fossa. This is the humerus and this is the olecranon. So the probe is made like this. So here is another picture where you can see the fibers of the triceps and you can see the tip of the olecranon, and this is the olecranon fossa. So if there is posterior joint joint effusion, then there might be fluid at this point. Now we have to check not only in the longitudinal view, but at the same point we have to check under the transverse view. And this is one of the case of the distal triceps tendon rupture from the olecranon. This is the area which is blank, and here it's all muscle has came to this point. Now, snapping triceps syndrome, I have already talked about this. This involves the anterior dislocation of the medial head of the triceps muscle and the ulnar nerve during the elbow flexion. And clinical presentation present experience the medial elbow pain, snapping sensations or flexion and extension, and sometimes the patient might have ulnar neuropathy as well. And a palpable snap is felt over the medial elbow during the flexion corresponding to the nerve and the muscle dislocation. And it is associated with the factors like the hypertrophied triceps. Sometimes there might be accessory tendon, and it have to differentiate it with the isolated ulnar dislocation. And ultimately, for the symptomatic cases, it requires a surgery, and asymptomatic cases do not require any treatment of. Okay. Now coming to the olecranon bursitis, another very common superficial bursitis which might occur. It is common because of the repetitive stress at that area and local contusion, and it may be associated with the other systemic disorders like rheumatoid arthritis, gout, sometimes the spondyloarthropathies, and sometimes the CPPT accumulation disorders. And in case of septic arthritis or the tubercular cases also, we have been found to have the olecranon bursitis. Now in the ultrasound, we will be able to see the large amount of fluid here, and sometimes there might be crystal deposition. We have to aspirate and send it for the culture and sensitivity to find out under the microscopy whether there is crystal, whether there is bacteria, or whether there is culture showing any infective bacteria as well. Okay, so here it is a comparison between a partial fluid. You can see here is the and in the olecranon bursitis, and here you can see a large partial fluid over the triceps. Okay, and here we can see the fat at the olecranon. This is normal. This is the olecranon bursitis. We can see partial fluid just above this area. So these are the basic pathologies of the area, and now it will be the demonstration. But if you have any question regarding this part, I will answer, and we will go for the demonstration. No questions. Okay. Let me log out from here, and I will be logging in from the another computer.
Yes, sir. Good evening, sir. Hello, sir. Mm.
Hello.
Yes, sir. Sir, radial cubital syndrome, the nerve involvement is posterior introsus nerve, sir. Radial nerve, sir.
What you are telling?
Radial cubital syndrome, sir. The nerve is posterior introsus nerve involvement, sir.
You are asking for the cubital tunnel syndrome or radial tunnel syndrome?
Radial.
Radial tunnel syndrome, here usually the compression is over the posterior interosseous nerve. Okay. And I have told you the 7 areas where it might get compressed.
If there is involvement posterior introsus nerve, there is a muscle weakness, no, sir. There is a motor weakness.
Before, see, if it is above, okay, then there may be both the symptoms because the superficial part is mostly the sensory part and the deep part is basically the motor part. So it depends where the compression is. If it is more at the after this arcade of Froche, okay, where it is entering the supinator, okay, then there are chances of the motor symptoms more. If it is anterior to it, then there might be both the motor and the sensory symptoms. Okay.
Okay. Okay.
তুমি একটু দেখো তো ঠিক মতো আমি করছি কিনা। This one share. Can you see the screen? Hello. Screen is visible?
Yes, sir.
Okay, I am audible also. So we will start with the just screen share. Okay. Screen এটাই তো বললাম তুমি স্ক্রিন করেছো। চল না ওকে দেবো এই তো হ্যাং হয়ে গেছে তারা বেশি ফাংশন একসাথে দিয়েছে তো একটু আগে তো ছিল একটু আগে একটু পরে তো Just a minute. Actually, my screen is hanged. কথা শুনতে পাচ্ছি না ওইটার দেওয়া যায় ওটা তো
Just 1 second, there is actually some issues. I'm just trying to solve it.
তুমি এদিকে অন করা আছে না?
সব বন্ধ আছে কি?
তোমার দিকে অন করা আছে তো এটা অফ করে অন করতে হবে না কিছু করতে হবে
আমার অন করা আছে।
মানে হস্ট আছে তো এটা বন্ধ করে দিলে ইয়ে হয়ে যাবে।
হোস্ট করবো একটু এখন আমি নিতে পারবো না। এখন আমি করতে পারি।
Yeah.
Yes, I'm just pausing for some time the recording.
Starting, we are going to see the lateral epicondyle first. Okay, so remember in lateral epicondyle side there are first we will see the muscle complex, tendon complex, mainly tendon complex, and below tendon there is ligament. Okay, so either the source of problem, any type of disease, pain, lateral elbow pain when patient is coming, either he has a problem in the tendon complex or below that is the ligament complex. Tendon and ligament to be understood separately. And 3 and 4 things is third thing is either maybe it is capsule and synovial complex, or inside that deepest thing that is joint. Okay, So joint problem here, we will not be able to see many. I mean, it is a normal thing only. Tendon complex and ligament complex. First, you understand very carefully. So, what are the muscles here? There we have actually first muscle here. If we start from last day, we have seen the anterior side of the elbow. So anterior side, when we were seeing the middle muscle was brachialis, and then there was a brachioradialis. So just after the brachioradialis, there are two other muscles coming like this. So what are the muscles? So one muscle is ECRL, one muscle is ECRB. Okay, then comes another three muscles. So that is extensor carpi, radialis, extensor digiti minimi, and your mainly extensor digitorum, and then the extensor digiti minimi, and then extensor carpi ulnaris. These three muscles will come. So we will see one by one. So this is upper layer, and behind that, I mean, deeper to that, there is one muscle that is called supinator. Okay, so just understand the orientation. Okay, before that, okay, now. So first you see how I am going to start the ultrasound. So here I can palpate the lateral epicondyle. Okay, this is the lateral epicondyle. Here, remember, this is the condyle is there. Below is the condyle, then there is epicondyle, and above that there is a epicondylar ridge. Okay, so ECRL, that is actually not a part of common extensor tendon. So that is coming from supracondylar ridge. Mainly the epicondylar ridge, from where the tendon starts, that is the ECRB. ECRB is a part of common extensor tendon. So here, left side of the screen is the left side of the screen is the humeral side. What you are seeing is humeral side. So first try to see the bony architecture. Okay, how the bone looks like. I'm decreasing the depth a bit. So first try to see the bony architecture. Okay. So just wait. Annotations. Okay, so see which area is what. This is the epicondylar area. Epicondylar. This is the condyle area. This is the radial head. Okay, so in our okay, so in our just a minute. Okay, so here you can see, so this bony margin, if we go like that, okay, this part is joint area. So if I make a 50%, make a line which divides this area in 50%, then upper parts remain for the common extensor tendon, and the lower part remains for the ligament. Okay, so this much we know from the previous basic classes. Now question comes that here, this area, this much only, not the lower one. This much has the tendon of 4 muscles. Okay, ECRL is not forming the tendon here. It is ECRL is going a bit above. That is called supracondylar ridge. And here there are 4 muscles. One is ECRB, then comes the extensor digitorum, then comes the extensor digiti minimi, and then comes the extensor carpi ulnaris. Okay, so how can we see those tendons, where they are coming and where they are joining? Okay, so try to see carefully. So now I am going directly in the short axis. Okay, so here what we can see, this round structure, this rounded structure, this is the radius. This is the radial head. This is the radial head. Okay. If I go in the right side, there is a muscle. There is a right side means this the radial side, this anterior side. If I go in this position, I will keep a bit like this. Okay, I will keep a bit like this. So radial head, and there are some muscles. So what are the muscles? Just first let us understand the muscles. Okay. So this is the radial head. This muscle is the supinator. This part of the muscle, actually here the difference is very vague, but then ECRB and this is ECRL. Okay, this is called tail of a scorpion look. This is a tail of a scorpion look. Why that is important? Because here it forms a tendon. This tendon is for ECRB. Okay. So first, let us see the structure. Okay, here as I told you, this is ECRB. This is this side is ECRL. This side is ECRL. This side is ECRB. This is the tendon, and this one is extensor digitorum. This is the extensor digitorum muscle. Okay. So remember, the till now this area, when this is the muscle belly. This has not formed the tendon because I am a bit distal. When I will come proximally towards the epicondyle, then it will form the tendon. Now I am seeing it a bit distally. Okay, so you can see all the muscles which I have told you, and this one's just under the yellow mark. This is the extensor digitorum. So let us come a bit more posteriorly. So there is another muscle. So this is called extensor carpi ulnaris. Now under the yellow mark, this is called extensor carpi ulnaris. Extensor carpi ulnaris. Then one muscle I could not see. That is the extensor digiti minimi. So where is that? Let us see the extensor digitorum first. This is the extensor digitorum. Okay, full muscle, and this is the tendon part. If I go a bit more distally, then I will see one more muscle will be coming from this side. Okay, so try to see. So again, I am going a bit distally. See, one more muscle has come. One more muscle has come. So this is called extensor digiti minimi. Okay. So in between this muscle is extensor digiti minimi. So muscle wise, now under the yellow mark, this is the extensor digitorum. Then this small part under the yellow, that is extensor digiti minimi. Then under the yellow, extensor carpi ulnaris. Okay. If I go more anterior side, Then after extensor digitorum, this is the ECRB and ECRL. And we are seeing this tendon also. This is the most important tendon because this is the conjoint tendon going to form the conjoint tendon. Basically, this is the tendon of ECRB. Now let us see why we are seeing this. Because from short axis, when we go to the epicondyle area, we can see the tendons one by one. Okay. So now under the yellow mark, this is the scorpion tail appearance. So this is the extensor carpi radialis brevis. Now I am going proximally, and you can see the tendon formation. Can you see the tendon formation? This is the tendon formation. Oh, wait. Okay, so see the scorpion tail. I'm going proximal, and this is the tendon is formed. This is the ECRB tendon. Okay, this is the ECRB tendon, the white part. But above that, there is one small muscle still there, and its tendon is here getting formed, lateral side. So what will happen? Let us first see the ECRB tendon. Now I can show you in the short axis. Let us see in the long axis. Left side will be humeral side. So I will make it in long axis. See. So ECRB tendon. You can see the ECRB tendon is in the middle part. Just okay. So this part is nothing but ECRB tendon. Okay. This part, this is the remnant muscle, still the muscle of extensor digitorum. Extensor digitorum. Middle part is ECRB muscle. Actually, ECRB muscle plus this is ECRB plus extensor digiti minimi muscle. Both have together forms the tendon. So what we have understood. So what we have understood that now we are seeing only the tendon. So up to this much to this much, these all are tendon. Okay. From there, then if we see layer by layer, then one upper layer is formed by extensor digitorum. Second layer is formed by extensor carpi radialis brevis, means ECRB, and extensor digiti minimi. But we cannot see the extensor carpi ulnaris. Now, why is that? Because they are not in the same plane. I have to go from this side to a bit this side to see the extensor carpi ulnaris. Okay. So now, so why I am so much stressing on ECRB? Because most epidural lateral epicondylopathy, this is coming from the ECRB itself and not the all other muscles. So here, as I told you that I can show you the, so middle part is ECRB, okay? Upper one is, as I told you, it is extensor digitorum. But am I correct? Let's see by making it short axis. Upper one I told you. So let you see that is the short axis, okay? Upper one is short axis. You know this is the extensor digitorum. From scorpion tail and after that this is the ECRB. You follow the tendon of ECRB. So this is the most important thing actually in the lateral. So this is the tendon. Okay. So follow the tendon. And you see this is the tendon is the second layer. Upper layer is the extensor digitorum. So you have understood. Okay. So now let us see in long axis. Actually, let us see that ECRB I have already shown you. Okay. Extensor digitorum you have understood. ECRL also you can see. I have to go a bit up, just parallelly up. Then I will see a big muscle. So this is called ECRL. This muscle is ECRL and it is coming and joining at the supracondylar ridge. So note the bony margin. Note the bony margin also. Supracondylar ridge will become like this. Whereas when it is the a common extensor tendon ECRB and all, then it is like this. Okay, so this is the difference. So this is ECRL. When I come down, this is the ECRB. Of course, other muscles are also there, extensor digitorum, then ECRB plus extensor digiti minimi. So let us now see the another tendon. That is the extensor carpi ulnaris. But before that, when I am seeing the ECRB, let us ECRB and extensor digiti minimi, let us see the tendon complex also. So remember, when I am seeing the tendon complex, I am not focusing on the ligament. But when I am focusing in the ligament complex, I am not focusing to the tendon. So now I am focusing in the ligament complex. Let us see the ligament now. So see what I have frozen it. So we have learned up to this much. Above that, we have learned. So now we will see below that. So muscle tendon is superficial. After that comes the ligament. So do you see a different type of structure below this? Yes. So this is the ligament. This is the ligament. So this part, this is actually radial collateral ligament. This is the radial head. This is of course cartilage, and another structure is here. It is there. So I will show it. But here, this is the radial collateral ligament. Remember this, if this is the area, radial collateral ligament going in this way, and another structure that is lateral ulnar collateral ligament that is going in this way, like a V. Okay. And radial collateral ligament goes in to radial head and joins with annular ligament. So do you think that this structure is a bit different? This fiber than this fiber? Both the fibers are different. So you can understand there is a gap here. So this is called annular ligament. So this is annular ligament. And this part is nothing but radial collateral ligament. Radial collateral ligament. This part we have already understood, the tendon part. This is the common extensor tendon. Okay. So this is the most important part. And remember, all views are not to see everything. Earlier views were to see the tendon. Now, so this is extensor carpi radialis longus. Now I'm coming to brevis. Then when I'm seeing brevis, then only by toggling, I can see the annular ligament and radial collateral ligament. Okay. So clearly, this is very clear. I think if I again just show you annular ligament. Radial collateral ligament. Remember, you should always see the margin of the bone also, so that you understand that in which area you have kept your probe. Now, last ligament and last tendon is extensor carpi ulnaris. We have not seen the extensor carpi ulnaris. So So let us see the extensor carpi ulnaris. So here I have already shown you the annular ligament and this one. So now what I am doing, I am going backward. I am going more backward, like posteriorly, this side. Okay, this side, this side. Then I will see the extensor carpi ulnaris. So you can see this muscle is nothing but the extensor carpi ulnaris, and this muscle has a insertion of so this is the extensor carpi ulnaris tendon. This is from just wait. So see the orientation, how I have kept the probe. So this is the whole muscle of extensor carpi ulnaris. Extensor carpi ulnaris. And from here, this tendon is actually going and joining in this side. Okay. To see it more carefully. Yeah. So this is the extensor carpi ulnaris tendon. So this is the extensor carpi ulnaris tendon. So now here also you can see ligament is there. Okay. Tendon, after the tendon complex, there is a line which is separating. So there is a line which is separating the tendon complex from ligament complex. Okay. So here I can show you that how the already I have shown you the radial collateral radial this one collateral ligament. Now I will show you lateral ulnar collateral ligament. Okay. So how I will show it? First, let us see the radial collateral ligament. So this part is for radial collateral ligament. Okay. Clean. So this part is radial collateral ligament. Now I will move the lower end of the probe towards the ulna in such a way that only fishtailing of lower end.
We are asking you whether you are available on 30th or not.
Tell me, please. Someone asking any question? I could not get it. So now what I will do, we are seeing the humeral side. I will fishtail the lower probe, lower end, and radius. I will miss the radius and reach up to ulna. So here I see a artery, see a pulsating artery. Okay. Just below that, this pulsating artery, just below that, there is the insertion of lateral ulnar collateral ligament. This one. Okay. Remember, so this one is a technique when this is the humeral side and this is not the radial side. This is the ulna. This is the ulna. Always see this arterial pulsation. In 99% of time, it will be there. And below that, there is the area of ligament. This is the area of ligament coming like this. So this is called lateral ulnar collateral ligament. Okay. This is sometimes a bit difficult to perceive because of anisotropy. So I can show you, this is the radial collateral ligament, and like this, when I go, I will see the pulsation of the artery. This is the clear ligament is coming and joining in the wait. So this is the ligament coming and joining in the ulnar head, ulnar side. Okay. So have you understood main the tendons and ligament complex? Anything in this area? Anything left in this area? Tell me. Have you understood all the muscles and all? So this is the ECRB, ECRL, lower group. Second layer of muscle is nothing but supinator. Upper layer, this is the ECRB, and if I go more anteriorly, this is ECRL. Then comes ECRB. This is the tail. Scorpion tail is actually the tendon of ECRB. Then comes extensor digitorum. Then comes extensor carpi ulnaris. If I go down, then there will be extensor digiti minimi coming out like this. Okay, in between. Weak. Yeah. Extensor digiti minimi. Okay, so this is the, and proximally if I go, already I have shown you. So just see again. From here, let us ECRB tendon. This is the scorpion tail. I'm going. So now, so this is the scorpion tail, which is coming and joining with the bone. So this one, this white area, if I may bring it under the yellow mark, okay. So this is the main tendon where you have to go for any intervention. Okay. So okay. So, another one important thing is the PIN nerve, posterior interosseous nerve. So just as already I know that which one is what, you have already seen that this one is your ECRB, ECRL muscle, ECRB, ECRL. If I go more anteriorly, then there is another muscle just under the yellow mark now. So that is called brachioradialis. Brachioradialis. So between brachioradialis and radialis, there is the neurovascular bundle is there. Okay. So this whole muscle, brachioradialis, and this whole muscle is nothing but brachialis. So you see this part. You see this part. So what we will see? We will see the radial nerve here. Where is the radial nerve? So this one is the radial nerve. So radial nerve will come, and actually this area supinator will arise. So it will enter inside the supinator. One branch will go inside and one branch will remain above the supinator. The deeper branch is actually a motor branch. Superficial branch is the sensory branch. So here you can see, so this is the nerve already I have told you. I mean, you can see it is the this appearance of nerve appearance, you can see clearly. So now I am going. So now supinator has arisen. You can see the supinator. So just above supinator, this one is one artery is going. Not artery, nerve is going inside. I mean, above the supinator. This one. Oh. So again, just see. So here. Okay. So between brachialis and brachioradialis, left side of your screen is brachioradialis and right side of your screen is brachialis. Now it will gradually go inside the supinator. Supinator will come. So just supinator has started to come, and this is the artery, nerve going above the supinator. Okay, nerve above the supinator, and one nerve you can see that is inside the supinator now. So just do it. Yeah, you can see this branch. This branch is inside. Here also above also muscle is there. There below also muscle is there. So this is nothing but the PIN. So this is nothing but the PIN. Okay. It is coming out from the supinator. Now it is coming out from the supinator. Again, I am going proximally to show you that it is inside the supinator. It is inside the supinator. Okay. Again, it is just going out of supinator, and it will enter in the plane between brachialis and brachioradialis. Okay. So you have understood this black spot. This is going inside the supinator. We can actually see this nerve in a long axis view also. Now, can you see? So if I come down, so see the breakage, see the break. Oh, yes. Okay. Now I'm putting it just under the. My volunteer is sleeping too much. Okay. So here you can see the deep branch of radial nerve. So this is the PIN. This is the PIN. Okay. This is going inside the supinator muscle. This is going inside the supinator muscle. Okay. I think you can see it clearly. This. So, any question in this part? Otherwise, I will show you the lateral, posterior side.
Once again, you can show me posterior intrusus nerve, sir. Short axis.
Short axis. Okay.
Just mark just.
Yes. Short axis. From anterior side, I am starting. So this picture you have seen last day. This middle part, all the muscle part is brachialis. Okay. Everything is brachialis. And this muscle is brachioradialis. Between them, this is the area for looking for the neurovascular bundle. So we will see it more carefully, and we can see very clearly honeycomb appearance. This is the honeycomb appearance of radial nerve. So this radial nerve will not divide here. It will divide when I come more inside the supinator. Supinator is a deep muscle here. Okay. We will not see the, here ECRL is there. Below ECRL there is supinator, and it will enter the inside the supinator. So you just see in between, you can see the honeycomb appearance. I am coming gradually. Now supinator has started. See this black muscle, this was not there earlier. Supinator, this muscle, this is the supinator. This was not there. If I go proximally, it will not be there. Nothing is there. So this is the end of humerus. So now radius has started, supinator has also started. Okay. So this honeycomb appearance, still I have kept it under the yellow mark in the middle part, but it will gradually enter inside. Actually, this Actually, this is also a branch. Wait, actually, this is giving you the honeycomb appearance, but this is also a branch. This is not a artery. This is also a branch of the nerve only. Okay. So when I'm going deep, so this is the same branch which goes inside the supinator, which is going inside the supinator. Just see. You can clearly see or not? This one inside, upper fibers, lower fibers of supinator. Okay. This is short axis view. This is short axis view. So now it is coming out of supinator. Now it is entering inside the supinator. Okay. So if I again from here, if I make it a short axis, I will be a long axis, I will be able to show you. So this one is the nerve. This one is the nerve. See, now it has entered inside the supinator. Yes, it is entered inside the supinator. I think you can see it clearly. I mean, there is hardly any confusion. Wait, where is that? Yes, so now it is entering inside the supinator. This is the nerve. This is the nerve. When it comes down, it goes like this. It goes like this. Okay. So this has entered in the supinator. And when it goes proximally, it comes out. You have seen clearly? Hello, have you seen?
Yes, sir.
Okay. So any more part in the anterior elbow? Not anterior, lateral elbow or any other thing, whatever I have taught you just now. Anything, any confusion anywhere? Mainly it is the ligament complex you must understand carefully. Okay. So now the only part remaining is posterior side, and that is a small area. Okay. So posterior side. So here it is a very small area. Lateral side. So here just see triceps has three bellies: medial side, middle part, and lateral part. So here, if I hold my probe like this, okay, so just try to see the tendon formation of lateral and middle portion.
Sir, camera out of focus, sir.
Yeah, camera. Just a minute.
Chinmada, it is focused. It is focused on the hand, not on the table.
Focused
It
on
is
the
clearly
hand.
focused on the hand. Yes.
Now.
It is focused, Chinmada. Nothing to do.
Oh, okay.
Out of focus is only the laptop and other things.
Okay. So here, what I am seeing first. Let me show you in this way. Yes. Okay. So try to see a tendon formation here. Actually, there is two tendon formation, one like this and one like this. This is the medial belly of the triceps, and this is the middle belly and lateral belly. of the triceps. Okay, so tendon will form like this and it will come up to the olecranon fossa to insert there. Olecranon process, not fossa. So try to see. This is I'm taking it to the lateral side and then middle side, and this is the one tendon, but one big tendon, and just by the left side another small tendon is there. So this small tendon comes from the middle belly of the triceps, but all the tendons ultimately come and join up to the olecranon. Here when they are joining at the olecranon, then also it will remain separate. Exactly. Okay. So under the yellow part, I am taking the tendon up to the, so this is the big tendon formation and it is coming and joining in the olecranon. So here you can see there are two small ball type of white part. So this is one tendon and this is second tendon. So these both the tendons are coming and joining in the olecranon process. Okay, so this is nothing but triceps tendon, and when we go a bit proximally, then actually we see loose areolar tissue in the olecranon fossa. So this is the olecranon fossa. We will see the loose areolar tissue there. So this is the olecranon fossa. This is muscle belly of triceps. This is the tendon part. Tendon, muscle, already muscle has started. And this area, nothing but the fat, loose areolar tissue or fat. So here it looks like this only. If there is a effusion, then there will be a black effusion like this, and fat will be displaced from this area. Okay. So this is the posterior side, and this is short axis view. I'm showing you just long axis view also of the triceps tendon. So how it looks in the long axis view.
Sir, olecranon bursa.
Olecranon bursa is a subcutaneous structure. In a normal patient, you cannot see, but I will show you the area of no issues. So this is the tendon, okay? So this is the tendon, you can see triceps tendon. And as I told you, the olecranon fossa. So this is olecranon fossa. This part is loose areolar fat. This is the muscle area, muscle. And this is the tendon. So so let us move and then you will understand it see the movement. So you can understand which is the joint. So joint space is here. Okay, this is one bone and this is another bone. So this is the olecranon process where coming and tendon is coming and joining, and this is the humerus part. This is the humerus part. So this is the joint. This is the joint area. Okay, but effusion is, this is the area for effusion. Okay, if there is a effusion. So like that only. I don't think anything more is there to show. So this is posterior elbow is over and lateral elbow is also over. If someone has not understood anything, please tell me. Any part, any confusion? Okay. Otherwise,
Muscles,
it
sir.
is yeah.
Muscles are a bit confusing, sir. Muscles. So
Muscles.
many muscles, sir.
Muscle. Okay, just a minute. I just show you. I wanted to show, but then this
Sir, you
computer.
are telling two muscles at a one bulk of muscle. At a ECRB and ECRL. It's in the same muscle. How do
That
you
is true.
differentiate
That is
between?
true.
How
That
do you
is
differentiate between?
I also cannot differentiate because nobody can differentiate. It is written in the book that ECRL and ECRB as a muscle bulk, you cannot differentiate. Okay, but we know the location that just beside the extensor digitorum, it is the area for ECRB. And of course, in MRI, everyone can, if someone correlates, then of course, I mean, they have correlated. And that's why they know that this is the ECRB area. But under ultrasound as a muscle bulk, it is hardly distinguishable. Okay, just a minute. I just tell you. Okay. I wanted to
Sir, common extensor tendon, the deep fibers are formed by the external carpi radialis brevis, right, sir? And superficial by ulnaris.
yes, just a minute. This is the most important part. Others are practically not that much needed, but this one you have to understand. Just a minute. Okay, so screen. Okay, just see. So just see that this is the elbow lateral side. So this one is ECRL. This one is brachioradialis. Of course, it is in the picture. This is brachioradialis. Let me hide it. After that, this is the ECRL. Oh. So ECRL, you can see that it has started from supracondylar reached. It is not in the condyle. So it is not a part of common extensor tendon. It is not a part of common extensor. If we hide it, then comes the extensor carpi radialis brevis. So this is the extensor carpi radialis brevis. Then comes extensor digitorum. Then comes extensor digiti minimi. Then it is the extensor carpi ulnaris. So 1, 2, 3, 4. So these four muscle, they are the part of common extensor tendon. Okay, again you see, so it starts from extensor carpi radialis brevis, and then extensor digitorum, extensor digiti minimi, and then extensor carpi ulnaris. Remember, supinator is there, but it is a deeper layer of muscle. So here it is the supinator, it is under the ECRB. If I remove it, then some part of supinator will come out. So height, yes. So you can see that supinator is there, but it is in the deeper side. Okay, supinator also has some attachment there, but still it is not considered as a part of common extensor tendon. Okay, then another thing I just wanted to show. Just a minute. Screen. Okay, another thing I just wanted to show. Where things comes out. Okay, see, So this is the, if from lateral side, when we see the elbow, so this is the supracondylar wrist and this is the epicondylar wrist. Condyle is here, so this is epicondylar wrist. In supracondylar wrist, this is the ECRL which is starting, and from here it is the ECRB and then extensor digitorum and extensor digiti minimi. Whereas the extensor carpi ulnaris a bit posterior. Okay, this side is posterior side, so this is a bit posterior. So when we are seeing these two layers, ECRB and extensor digitorum or digiti minimi, then you cannot see extensor carpi ulnaris. So remember, here actually two layers we are seeing, but of course here is together it is written, but this is the extensor digitorum will be above the ECRP. Then supinator also has some attachment, and then comes the lateral collateral ligament. So see, this is what I was showing you. ECRL looks like this. Mainly you see the supracondylar ridge. This is like a triangular area. Okay, then comes in this way. So ECRB, extensor digitorum, extensor digiti minimi, all these muscles come here, but extensor digitorum is the most superficial muscle. Then comes extensor carpi radialis brevis and extensor digiti minimi. Okay, then of course here ligament will come. Extensor carpi ulnaris will not come. We will see when we go a bit posterior. Okay, and when we will see a bit posterior, then actually we will see the lateral collateral ligament. Mainly in this area also we will start seeing lateral collateral ligament. Okay, in lateral collateral ligament complex, it is not only one ligament. So mainly the radial part we will see here, and when we will see the extensor carpi ulnaris, we will see the lateral ulnar collateral ligament. Okay, so you see this is the ligament. From here it remains same to the radius, but I was doing fishtailing to come to lateral ulnar collateral ligament. This is radial part. This is radial ligament, and this is the lateral ulnar collateral ligament. Okay. So this one already I have shown you. This is not very good. Okay. So posterior elbow also. So mainly this part only. Okay. You try to see the recording many times, then you will understand the orientation of the muscles. That is very much necessary. That is very much necessary. Otherwise, and once you understand the muscles, then you can go to in a short axis to the tendon part. Then it becomes much easier to understand which tendon is what. Okay. I think this much only. Devjyoti, nothing else? I think it's okay.
We can conclude the class for today.
Yes.
Thank you all.
Okay, thank you.
Study
Any
material
other?
is already posted.
Yeah.
And the MCQs I will be posting soon.
Thank you, sir.
Okay then. Thank you.